Hi, welcome to Vera Voices. I'm Michael Jacobson, the director of the Vera Institute. We're here today with Ernest Drucker. Ernie is a professor emeritus in the Department of Family and Social Medicine at Montefiore Medical Center in the Einstein College of Medicine. He's also currently a senior scholar and researcher at the John Jay College of Criminal Justice. And for the purposes of this talk, also the author of a relatively new book on prisons from a public health perspective, an excellent book called The Plague of Prisons. Well, thanks so much for being here. So let's start off with a sort of broad question. There's obviously a huge and growing literature on mass imprisonment and over-incarceration. There's not much, however, written or researched on it from a public health perspective, which is your perspective. So how do you, from a public health perspective, sort of see this issue?
I think the biggest difference between a criminal justice view of incarceration and the public health view is that the criminal justice view, like medicine, is based on the idea of a case, crime and punishment in this case. In medicine, it would be disease and treatment, but it's an individual matter. And public health deals with populations. It deals with collectivities of people and what happens to them and why it happens to them as a group.
Your book describes incarceration as an epidemic,
Right,
in sort of health terms. And so what does that mean in criminal justice terms?
It means that and in a way it starts as a metaphor. You know, something's growing fast and it's a problem because of that. But as I looked into it and did the research for the book, even though I'd worked as an epidemiologist for many years, I was surprised that it's much more than a metaphor, that actually mass incarceration operates more like an infectious disease epidemic than I would have imagined. So what makes an epidemic? Three things. One, that it's a change from business as usual, so it's that upward swooping curve. Then it has features by time and place and person. It happens somewhere, it happens someplace, and it happens to some people more than others, the risk factors. So when you apply those to who's in prison, you get dramatic disparities, for example, by race, by part of the country, by economics. And then you have transmission, how it gets from an infectious disease especially. It's not true of chronic diseases like heart disease. But how it gets from one person to another. Does it have those features? Why would it? And it turns out that because a guy goes to prison and there are all his family members affected by that, the affected population is much, much larger than the individual prisoners.
I guess one of the obvious questions, especially coming from a place like Vera, are what are the policy outcomes that, given a public health perspective, are either compatible with or in addition to the usual policy prescriptions for dealing with mass incarceration?
In a way, to get to that question, I should go through one other. What do you learn from the public health, putting the public health lens on this? And what you gain is an understanding of the degree to which things that happen a little bit to one person and a little bit to another, when you put it all together, makes a big difference. For example, felony disenfranchisement, losing the vote, is something that applies to 6, 7, 10 million people at a given time. And there's vast confusion about what the rules are for getting on and off it, and the rules change from state to state from time to time. So you have a system there that is biting into the representation of huge populations of people. That you wouldn't think of when thinking about a criticism of how prison is tough on people.
Right. So calling it an epidemic, you understand analytically why that makes sense and why it's a good lens to look through mass incarceration. Are there any specific suggestions that you have that are relatively new?
Well, they're not so much as suggestions as a different way of looking at it, such that you ask different questions and look at different outcomes. Public health operates is preventively. So what are we trying to prevent here? And then the other thing is it has these ideas of levels of prevention: primary, secondary, tertiary, where primary is prevent the disease, secondary is treat the disease, and tertiary prevention, the third line, is you can't cure the disease the person has as a chronic disease, limit the damage that it does to their lives. Primary prevention, put fewer people in prison. How do you do that? you change. You look at the laws that put them in prison and which ones you can afford to back off on. Obviously, you tip towards public safety. Secondary prevention has to do with, you've got people who already are in prison, and many more of them who have been in prison, and profoundly affects their lives. Harm reduction. How do you reduce the damages and turn some of those into assets? And tertiary prevention has to do with the climate, the situation which fosters mass incarceration, punitiveness, playing politics with the prison issue. So you go through, systematically go through the things that put people in prison and say, who can we afford not to put in prison? No matter how much we like to do it. How can we not do it? Because it's not good for the society.
You know, what's your thinking about whether this or other things will actually start to generate more interest in the public health field around these issues?
The place you start always, if you have a long-term view of what you want to do, is with students. I've been working with law school at NYU and learning about legal education and realized that law education includes nothing about the drug laws. I focus in the book on the drug laws and their singular power in filling the system. But it turns out that law students have no exposure to drug laws, drug case law, the logic of drug laws. And wonderfully, it's in the hands of law students. There's a wonderful group called Law Students for Sensible Drug Policies, organized in the US, Canada, Australia, and some European countries now, and South America as well. They have about 50,000 members, and they have chapters in all these schools. So what we've done is develop a questionnaire, a survey questionnaire, asking basic questions about drug laws. And do law students know about those? And we're going to do those similar, analogous things with public health students.
What is, from a public health perspective, the end goal here?
The goal is to get the prison system down to the same size as other countries like ours have it, which is about 1/7 of our system, as it was for the 80 years before it ramped up in the epidemic. The epidemic is like this. It peaks and goes down again, and it's on its way out. New York State especially.
Right. So getting us back down to where we were, let's say in the
60s.
mid-60s, before the huge increase began, when we were at about the same rate and numbers as most other, certainly industrialized countries, certainly Western Europe.
Right now, the European Union countries, which have a population of about 400 million people, have a rate about 100 per 100,000. We're operating at 700 per 100,000, so there's room for improvement. But there's a clue in it, in that the entire European Union has fewer people in prison in total, about 400,000, I think, than we have in prison for nonviolent drug offenses. When you take something like drug use, especially my concern, and decide to make that the basis of putting an extra, over the course of the 30 years, we've put an extra 5 or 6 million people in prison. And the impact of that sort of echoes down the generation. It's this huge stressor for a population, especially poor minority people, who have enough stressors to begin with.
Well, thank you so much. It's a fascinating book, and thanks for coming and talking to us about it.